One of the challenges in this beautiful old building is that when it was built back in the early part of the last century, they did not have built-in speakers, loudspeakers, the way many vacation homes would today. It's hard to believe this was actually someone's vacation home. The Verrills were the owners of this estate, and this is in fact the second house that was on this site. Mr. Verrill had a first house built that was as big as this, in sort of a Cape Cod and Nantucket style, and he lived in it for a couple of years, summers, and decided he didn't like it, so he had it burned to the ground and started again. We were happy with either one. I want to welcome you all this evening to St. Joseph's College. My name is Jim DeLugos, and I have the great privilege of serving this college as the current president. I am the new current president. I just began my time here in July. Came up to Maine from north central New Jersey, having served the last 7 years at the College of St. Elizabeth in Morristown with Sisters of Charity. So I know a couple things about Catholic healthcare. And I'm delighted to be here to welcome you all this afternoon to what we will, in the best tradition of academic endeavor, term the first annual Sister Consuela White Lecture. We hope this is the first of many, many of these gatherings to bring people together in the spirit of Sister Consuela to talk about matters of concern in the healthcare field. We want St. Joseph's College to be a gathering place for people from all over, from all different walks of life and pursuits, to come and spend time listening and conversing. We're grateful for all the partners we have in that. And of course, the primary partner this evening that we want to recognize is Mercy Hospital. We're delighted to have with us Eileen Skinner, who's the president of Mercy Hospital. It is our centennial anniversary year. The college has been not here, but the college has been for 100 years this year, and so we're in the midst of that celebration, and we're delighted to have this event as part of that ongoing celebration. At this time, what I'd like to do is simply to introduce the next speaker, Sue Henderson, who will tell us a lot about Sister Consuela. So have a wonderful evening.
Okay, thank you. It's really an honor to be invited to speak to you, say a few words tonight about Sister Consuela. I was privileged to know her over a period of 36 years, so I'd like to share some of my memories with you and hope that they will be meaningful to you. Sister Consuela was born March 26 in 1920, and she died at age 91, May 26, 1911. What? 2011, thank you. Okay. And she died at the Francis Ward Convent in Portland, and I would go visit her there, and she would share more about her early years. So I put this next slide on. This is Revelstoke, British Columbia, Canada, and this is where Sister Consuela was born. Her father's family had a farm in New Brunswick, Canada, and when he was newly married, he took his new bride and they went to Revelstoke in order for him to work on the railroad there. Revelstoke was a railroad hub, and you can see it's in the beautiful mountains of British Columbia. They stayed there. Sister Consuela was born there, Florence Mary White, and after a short while, the family was called back to the farm in New Brunswick, where Sister Consuela grew up, New Brunswick, Canada, and the family added another brother and sister. Now this is just a farm. It's not their farm. It's just a farm in New Brunswick, Canada. I'd never been there. But I always had the impression of Sister Consuela that some of her characteristics were shaped by someone who had a deep interaction with the land. She always had an appreciation of nature. She had a fondness for animals. She talked of going on horse-drawn sleigh rides, and one of her friends said that Sister even drove the horse and sleigh, and they would go by sleigh to school or to church. And Sister Consuela had immense practicality and common sense. Very, very grounded in basic common sense and practicality. And she also had a marvelous sense of humor. She would obviously had a very happy laugh at joy, but she also had a funny little laugh at our foibles when things went wrong. She'd kind of just laugh and say, "Oh, look at us! This is how foolish we are," and that was a good laugh too. Now, she graduated from high school in 1937 and attended the Madigan Hospital School of Nursing in Halton, Maine. While she was there, she said at one time to me that when she was a student, she felt like she could hardly wait to graduate so that she could belong to the American Nurses Association and begin to shape her nursing profession. She, I think, always had a vision and an eye for leadership, and I think a thirst for knowledge. I think Sister Consuela perhaps was the kind of learner that just integrated knowledge. After she graduated from the Madigan, at some point she studied at George Washington Catholic University in Washington, D.C., and then she got a master's degree in nursing and a baccalaureate degree in nursing from Boston University. And she definitely was a lifelong learner, and she clearly integrated her profound faith with her learning. So she's a very, very visionary woman. This is a picture of the land around Halton, Maine. And the reason I just put that there was thinking this is the service area where Sister Consuela's patients came from when she was a student nurse. And she often spoke of doctors driving by the nursing school and getting student nurses to go out and assist in home deliveries. So that's kind of some long drives to imagine. One time she kind of confided that she had been to a home delivery and there was an open flame in the room, and the doctor used some kind of volatile substance to relieve pain, and Sister was very afraid. So later I asked her about it, and she didn't want to talk about it because I think her great sense of dignity, that she didn't, maybe thought it would make not a good image of someone. But she had amazing experiences. In 1944, she entered the Sisters of Mercy. This is the convent on Stevens Avenue, and she became a Sister of Mercy. And then when she finished her time at the convent, she went back to the Madigan, and she was director of nursing and director of the School of Nursing at the Madigan until she went to Mercy Hospital. And in 1952, she was invited to be the director of nursing services and the head of the nursing school at Mercy Hospital. Someone said about Sister that she was a giant of women in healthcare, a giant in healthcare in Maine. She was on so many boards. She was a leader in the most profound sense of the word. She, in terms of nursing, served on the Maine State Board of Nursing. She had served as president of her state nursing association and had been a trustee at Mercy, just very, very active in a leadership role. Now, in 1974, Sister came out to St. Joseph's College to found the nursing department. St. Joseph's College was the second baccalaureate program in the state when the program was started. The only other baccalaureate program was the University of Southern Maine. If you can see this slide well enough, you can see that these are the dorms over here, but none of the other dorms are there. The Alphon Gym is not there. The library's not there. The big building's not there. So the college was tiny when she came here. And that is where I met Sister Consuela. She came and taught the freshmen, and then she hired Francis Linehan and I in the spring of 1975 to start teaching the sophomores when they would come in the fall. It would be the first class in the fall. And so we were very privileged to be part of planning the whole program, like designing the nursing lab, picking our first clinicals, choosing what was going to be in the classes. And so we spent a great deal of time with Sister Consuela. And one other special privilege for me is that Sister didn't drive a car, and she was living at Vaughan Hall in Portland. So a lot of times I would drive her home, and we'd have that extra time to talk in the car, which was really great. Now, I remember still very clearly my first meeting with Sister Consuela. I think I had never sat down with a sister before. I'm a Protestant person, and I haven't had or did not have much experience with sisters. And I went, and she had an office upstairs in Mercy Hall, and she was sitting there. And I don't think I understood at first, but this was her way. She was incredibly still, and she would attend to you with all of her senses. She would listen to you with her ears, but she'd also listen to you with every sense in her body. And this total being present with you encouraged you to trust her and to share with her. And I think that this is what students would say about her, that she would get to know all of the students, like her freshman students. She taught the freshmen professional nursing, and she took the time to know the students and the faculty. As I got to know her through the years more, I came to realize that she was never naive about someone's weaknesses. Sometimes if someone says, "You can do it, Sue, you can do it," and you say, "Yeah, if you only knew me." I couldn't. But she knew your weaknesses and your shortcomings, and she still had this faith in the good in people. That, yeah, I know you're not perfect, but there's a lot of good in you, and you can do it. And I think that, to me, was just incredibly empowering to myself, to faculty, and to her students. She wasn't one to say to the students, she was very compassionate, but she'd never say to a student, "Oh, you poor dear, I'm going to let you off easy." No, the heads are shaking. She would say, "Oh, it's hard. Let's find a way for you to do this." And she would really help people achieve and be there for them. Now, I think, yes, this is the first class at St. Joe's, and it's the capping. She brought the tradition of the diploma program to our school, and that was probably February of 1976, where she's capping the first class. At the capping, they sung the prayer of St. Francis. And at every capping or lighting ceremony since, the prayer of St. Francis had been said. Sister used to have the freshmen say this prayer in the class, professional nursing. I think that the prayer reflects her leadership style, that this is how she lived her life, to try to achieve the words of this prayer. After she left St. Joe's, Sister Consuela, she retired in 1986, and then she went to Mercy and was vice president for mission effectiveness at Mercy Hospital. When she retired from that job, the hospital had a beautiful banquet for her at the Eastland Hotel. And at that Eastland banquet, the whole ballroom sang the prayer of St. Francis. And it was really beautiful. So now this picture here, I believe, is in the hall of Mercy Hospital. And in talking a little bit more about Sister Consuela's leadership style, she always began interactions by talking about you, asking, "How's your family? How are you?" And then she would spend time building community before she'd set about doing business. She tended to ask questions until answers were found. And she was humble, very, very respectful, and yet assertive. She would say what her truth was in any situation, but she was extraordinarily respectful and humble. Now, there's many awards, I think, named for Sister. I just want to go past this, say one more thing about this slide. After Sister Consuela retired from her formal job at Mercy Hospital, she still lived across the street in an apartment on Winter Street. And she would love to come over to the hospital and have her meals and make rounds. And long after Sister had an official job at Mercy, official paid job at Mercy, I think she did some very excellent nursing care and provided healing for patients and for staff. And she would make rounds through the hospital. She'd see things. She'd talk to patients. She'd talk to staff. And that was very, very, very dear to her heart. Mercy has a Sister Consuela White Award. ANA Maine has a Sister Consuela White Award. It's a Spirit of Nursing Award. And this award was the leadership qualities we chosen because I thought they really reflected Sister Consuela's skills as a leader. She really listened on a deep level. She was present with people. She was never judgmental. She always had an open mind. And she was very, very astute in dealing with ambiguity, paradoxes, and complex issues. The other thing is that she honestly believed in sharing critical challenges with all parties would get to the end, that was more important than telling people what to do. I mean, when I think back of her leadership in the department, I don't ever recall her saying, like, this is what you should do. But somehow she got us there. And I think it was that asking questions and helping us understand the goal and pointing the direction. She had great foresight and intuition, and she was able to see holes and interconnections. As soon as the program got started at the college, Sister Consuela realized that we needed an avenue for RNs to get their BSN, and she immediately laid the groundwork for the RN to BSN program. I think nursing is just catching up to some degree with Sister Consuela's vision of what nursing could be and should be. You know, sometimes some of the things in the IOM reports about nursing's role, importance for patients in the nation are things that Sister, I think, felt in her heart. Now, the year before Sister Consuela died, I was very involved in ANA Maine, and I was a judge on the awards committee. And there was a nurse who graduated from Mercy Hospital named Katherine, Murillo, I guess I can say her name. And her co-workers nominated her for the Sister Consuela White Award. And I got to read the letters that these co-workers wrote. And they were so deeply moving to me that I put them all in an envelope and sent them to Sister Consuela. And then Katherine did win the award. And then at the awards ceremony, Katherine said, I'd really like to see Sister Consuela. Could I see her? So I said, okay, I'll set that up. So Katherine and I went to meet with Sister Consuela at the Francis Ward Convent. Now, Sister knew we were coming, but when we arrived, I could almost see a little bit of anxiety in her face. I could see her thinking like, all right, what am I supposed to do with this woman? You know, and so we went upstairs and we sat down, and Katherine talked to her and said, I had you in class, Sister, and I really enjoyed your class. And then Sister remembered, oh yes, and so they talked for a while, and we're sitting all face to face in a circle. And then Sister Consuela said to Katherine, "Now, dear, what do you do in nursing?" And Katherine said, "Well, I work with the mentally ill homeless." And Sister Consuela's face just lit up. And she said, "Oh, my dear, God's love is manifest in the nurse-patient relationship." And to me, that's Sister. So, and then when she retired, I think she had retired and the seniors asked her to come back and speak at pinning. And at the end of her pinning speech, she ended with that quote from Micah. So that's my sister.
Sue, thank you so much for that moving tribute. Hi, I'd like to introduce myself. I am Barb Higgins, and I am the new chair of the Department of Nursing here at St. Joseph's College. And it's an honor to be here, both in my role as the chair and also to welcome you here this evening to this wonderful event and this tribute to Sister, as well as this lecture that we're looking forward to about nursing and health care. I come from an organization that is that was one of the first in the state to combine an educational and a clinical and a diploma nursing program and a college together to form a baccalaureate nursing program years ago. So to me, I think it's wonderful to be a part of any type of education and clinical collaboration that can be done. And so I'm particularly excited tonight that this is something that's being sponsored by Mercy Hospital and done here at St. Joseph's College. I've really always admired institutions that have recognized nurses for their leadership roles, and so from that perspective, I very much find that the choice of Catholic Health East in recognizing our speaker is one that is well made. And it's my pleasure now to introduce our speaker for the evening, Judith Persichilli. I'd like to just share a little bit about her and then turn the microphone over to her. Judith currently serves as CEO of Catholic Health East since 2009, after rising through increasing ranks of responsibility and authority within the organization. And prior to joining Catholic Health East, Judy served for 8 years as the CEO of St. Francis Medical Center in Trenton, New Jersey. Judy started her healthcare career as a diploma nursing graduate of the St. Francis Hospital School of Nursing, a BSN from Rutgers University, and a Master's of Art in Administration from Rider College. She has also received honorary degrees from Georgian Court University and Sacred Heart University. Judy has been honored for her work in healthcare by a variety of organizations. These include induction in 2006 into the New Jersey State Nurses Association Hall of Honor. And in 2008, she was awarded the Richard J. Hughes Humanitarian Award, the Catholic Charities Diocese of Trenton's highest honor. Last year, Judy was awarded the Bene Merenti Medal, a papal honor bestowed upon her by Pope Benedict XVI. It is with great respect and admiration that I ask you to extend a warm welcome to Judith Persichilli.
Thank you, and it's really a privilege to be here. One of the first times I visited Mercy Hospital, Eileen introduced me to Sister Consuela. So I really feel honored to be able to talk tonight and very excited about a conversation with you on healthcare reform. Sister Consuela was certainly a leader in nursing, and she was probably a leader in reform. And I think there's a lot of lessons to be learned from just knowing her. So thank you so much. Let me tell you a little bit about myself. When I hear those introductions, I really I don't know who they're talking about. So when I wake up in the morning and I look in the mirror, I see a nurse. That's all I ever wanted to be, was a nurse. And I loved it. I loved being a nurse. I worked for about 5 years as a diploma nurse in critical care. So how did I end up being CEO of a $5 billion enterprise called Catholic Health East? Well, it's really interesting. I went to a diploma school, St. Francis Hospital School of Nursing. I loved it. I mean, I read all those Cherry Ames stories about the nurses swirling down the hall, all the cute doctors. I just thought, I loved even the bibs we wore, and they were like down to our ankles. I used to put that on every morning and say, this is who I am. And I worked for 5 years in critical care, absolutely loved it. And we're gonna talk about some lessons. I had a director of nursing came up to me. I think I had been transferred to recovery room for a day. And she said, you ought to think about going back to school. So I did. I went back to school and I got a Bachelor of Science in Nursing. And then I worked full-time and went part-time to graduate school. And they called me back to the hospital, and it was when the Joint Commission standards were coming in on quality assurance. And Sister Agnes Marie, love of my life, said, Judy, I want you to start a hospital-wide quality assurance program. So I said, fine. And I went to work every day, and I loved doing that. So there's another lesson number one. The one thing I learned is nursing is vitally important to the patient experience. And this is going to break your hearts. Now, Eileen told me I could be a little controversial. Nurses, we really are not the center of the universe. There's a full village that takes care of patients. And when I started learning all the standards across the hospital and how vitally important everyone was, it was a great lesson to me as a nurse and as a leader. But it didn't come back to me too much later. So one Friday afternoon, Sister Agnes Marie called me into her office. And I thought, why is Sister calling me? You never like that on a Friday afternoon, by the way. Why is Sister calling me into the office? And she started talking to me about the new reimbursement scheme called DRGs, Diagnostic Related Groups. Now, New Jersey was the experiment. We did it before the rest of the nation. That's where the clinical and financial aspects of how you got paid came together. And although I thought it was really interesting, I wasn't quite sure why she was telling me all of this. After all, I was in charge of quality, and that was not going to change. She told me that she had hired some CPAs to help in the finance division, and they didn't have any clinical knowledge. So she thought it would be a really good idea if I joined the finance department. Sister, no thank you. Nice try, Sister Agnes, but I'm not going to do that. I love quality. I love my job. She said, okay, Judy, and I left. I had a wonderful weekend, and as I like to tell it, I came back, and my office was moved. The whole office was moved. So, starting that Monday, I spent 4 years in the finance division. I spent years managing medical records. They don't even call it medical records anymore. Patient registration. I did the revenue cycle. Credit and collection. And so we pay for this? You've got to pay for this? I was in way over my head. Lesson number 2, when an opportunity to learn and grow presents itself, don't say no. It could be life-changing, and it certainly was for me. So it was about 3 or 4 years. I always like to say I spent 4 years of a decade in the finance department fighting with the CPAs. This was our lunchtime conversation. You don't understand finance. You don't understand clinical. Okay, I'll take the CPA exam and fail. You'll take the RN exam and fail. you'll fail worse than me. That was the extent of our conversation. That's how much I had in common with those boys. Well, once you're a nurse who's worked in finance, your career options just open up, and the rest is really history. At some points in my career, I've provided oversight to just about every department in the hospital, facilities, housekeeping. And you know what you learn, and this is the best lesson of all, is that the people that work in hospitals are really special. I don't care what they do, we need every single one of them. I participated in more strategic planning sessions that I care to remember, some that actually worked, by the way. So has any of this prepared me for the changes we're about to experience with healthcare reform? Well, maybe not specifically, but I would say generally, absolutely. Because my career has been one of flexibility. It's been one of change. And we're about to experience the biggest change in U.S. healthcare in a century, in 100 years. But before we speak about the future, I think we first must reflect on the past. The stories of our founding congregations inform us, they inspire us, they give us hope, and they speak to the courage that we need today to meet the challenges of healthcare reform. Courage, faith, risk-taking. Every religious community has its stories. The real soul of those stories comes to life every day in hospitals and healthcare systems. Some of you know the stories better than I. They came from Ireland, Italy, France, and Canada, more than 150 years ago. They brought their joy and their courage. They were pioneers. They were leaders. They were penniless. They took the risks necessary to bring hope to the poor, the vulnerable, the marginalized, women and children, the elderly and frail, those who had no voice and no one who cared. They brought their special and unique gifts, their charisms. Many sisters traveled long distances to this unknown land with little more than $1 in their pocket to bring their special gifts to communities in need. Their special gifts carry on to this day. The ministries of the Sisters of Mercy continue with their focus on unmet needs with a passion for those who are economically poor, especially women and children. Joy, courage, healing, community, the poor, women and children, immigrants, the marginalized, with humility, simplicity, the love of God and selfless service, but most of all, risk-taking are their stories. What have we learned from their stories? Most of all, to have courage right now and dare to take the risks our faith demands of us. As we study these stories, we learn the risks the sisters took to continue their mission. And most importantly, their ability to change in response to need, to let go, to begin anew. Hope for a future better than the present we live in. Hope. A feeling that what is wanted will happen, to trust that it will happen, based on trust in God's love, a powerful trust that healthcare reform will fulfill our hopes for a system of better care, better health for populations, and lower costs. And as we like to say in Catholic Health East, that's triple aim. And we say triple aim +1. Better care, better health for populations, lower costs, and protect the poor. So what distinguished these sisters, these pioneer sisters, many of them nurses over a century ago? They were leaders. Leaders in the changes that were necessary at the time to respond to the needs of communities they came to serve. None of the founding congregations started caring for people in hospitals. They cared for people in their communities. We just heard that story. They cared for people in their homes. When they saw a need for hospitals due to perhaps contagious disease, they figured out a way to raise the money to build what they needed. They are examples of the leaders we need in healthcare today. And many of them were nurses. John Cotter the author of Leading Change, I don't know if you've read that book, I recommend it, reminds us that leaders establish the vision for the future and set the strategy for getting there. They cause change. They just don't wait. They motivate and inspire others to go in the right direction, and they, along with everyone else, sacrifice to get there. Sacrifice is hard. Change is very difficult. We are approaching an era of disruptive change in healthcare. Clayton Christensen, the author of The Innovator's Prescription, A Disruptive Solution for Healthcare, another recommended book, discusses disruption in healthcare, disruptive innovations, as a growth opportunity if modeled appropriately. But as you know, disruptive solutions and innovative change can pose a significant threat to the status quo. That is difficult to break through. Aren't we experiencing that right now? The fear of change in our healthcare system? We have all experienced disruptive change in healthcare. When I first started, many of you, as I look out there, I know many of you know that our cholecystectomy patients, they stayed in the hospital for 2 weeks, right? Now gallbladders are removed with minimally invasive procedures and patients stay 1 day. All of us can recall the introduction of angioplasty and as an alternative to more costly and invasive cardiac surgery. No more is it a foregone conclusion that your chest will be cracked open, your heart stopped, and your vessels repaired, because we can put a stent in. That was unheard of 20 years ago. You feel disruption in the marketplace. It's all around us. Retail clinics. Did you ever think that you could go into CVS and get taken care of? Medical tourism. All right, how about Walmart? That's even more unusual to me. Medical tourism, technology-enabled self-care for those of you that are in home health. The introduction of technology-enabled self-care into the home to be able to monitor patients. How about our Coumadin patients that are now doing their own INRs at home, where they used to go every month to a clinic to get it done? These are all disruptive innovations challenging the status quo. These and other new phenomena zero in on simplification, convenience, unmet needs, and leveraging technology and new business models to deliver enhanced value at a lower cost. And when they work, they change the game. So what's all the noise about healthcare? What's all the noise about healthcare reform? Doesn't it make sense if we can improve the health of communities, lower the costs, improve the quality? Doesn't that make sense? So why is there such controversy? Well, this might be part of it. This could be a very expensive operation. I'm going to refer you to the federal government. Isn't that the fear? It's because the business model in healthcare in the United States actually has been frozen in two basic models. The general hospital, we're all familiar with, and the physician's office. And if we are to produce the value equation we aspire to, better care, better health, and lower costs, the business model has to change. If we are to make healthcare more affordable with better outcomes. Let's look at the statistics. The cost of care is skyrocketing. There's been a 76% increase in the cost of care in the United States between 1999 and 2011. It's approaching 17% of the GDP. Approximately half of the healthcare dollar goes to hospitals and providers. The unsustainable costs are due to the aging baby boomers flooding the Medicare rolls. Not quite yet, though. Longer life expectancy. Remember, when Medicare was put in 1965, the life expectancy was 15 years shorter than it is now. Cost of technology and pharmaceuticals. Now let's talk about Medicaid. Medicaid costs are also skyrocketing. This is a disturbing statistic. 17.6% of United States citizens are living below the federal poverty line, almost 20%. That impact on state budgets is unsustainable, roughly a quarter of state budgets. Some of you may be saying, well, really, so what? We have the best health care in the world. Of course it is. And it's going to cost money, right? Let's take a look at the statistics. Our quality of care, unfortunately, falls short of the mark. Life expectancy, preterm birth, infant mortality, and other measures lag well behind those of developed nations. In 1999, the Institute of Medicine published a report, To Err is Human, and called attention to the toll of medical errors. 15% of hospitalized patients are still harmed during their hospital stay, and roughly 1/5 of Medicare patients are rehospitalized within 30 days of discharge. The math is simple. Too much is spent on health care without a concomitant return on quality. Bottom line, quality needs to be improved with a simultaneous reduction in costs and elimination of waste. So what's the solution? How do we do this? Or maybe the question is, what would the sisters do? They would sacrifice, wouldn't they? There are sacrifices to be made by all involved if we are to realize a person-centered healthcare system with access for all. So let's start with the numbers. There are approximately 800,000 physicians and surgeons in the United States trying to help approximately 300 million people lead long, healthy lives. Taking part in that effort are about 2.5 million nurses. Keep that statistic in your mind. 400,000 medical assistants, 235,000 pharmacists, 300,000 lab technicians, 120,000 paramedics, about 100,000 respiratory therapists, I think only 8,500 nutritionists. Get the problem? And many, many more, millions of people, all essential to the healthcare system, needing to speak with one another, not past one another. Millions of people to sacrifice individual wants and needs to bring forth a new order of things, a person-centered, integrated network of care. Half a century ago, healthcare was neither costly nor really that effective. I'm sure some of you remember half a century ago. I'm getting real close. You know, every time I talk about how long I've been out of school, I round down now. So Sister Mary Persichilli, our Vice President of Mission, one day said to me, Judy, you've been saying 40 years for the last 5 years. I said, that's not fair. That's not fair, sister. That wasn't very mission-oriented. Dr. Atul Gawande, I don't know if any of you have read his work, primarily in the New Yorker. He shares that in the last 50 years, science has combated our ignorance. It has enumerated and identified, according to the International Disease Classification System, more than 13,600 diagnoses. That is 13,600 different ways our bodies can fail. And for each one of them, we tried to discover a remedy, didn't we? Remedies that reduce suffering, extend lives, and sometimes stop disease altogether. These remedies now include more than 6,000 drugs and 4,000 medical and surgical procedures. No one will ever master the understanding of all of this. So what did we do? We embraced an era of specialization. We worry about a particular segment of the human condition, rather than the larger question of whether we as a group are making the whole system of care better for everyone. Having great components is not enough. Having all those great components working together to provide the best possible value of caring is the key. So what is the challenge in front of us? We need to bend the cost curve. The centrifugal force should help to dislodge your kidney stone. It's a lot cheaper than what we do today. And notice that nurse has 3 arms. I know the nurses in the room sometimes feel that they could use 3 or 4 arms. Bending the cost curve while improving outcomes, focusing on prevention to improve the health of communities, decreasing hospital-acquired conditions, improving quality core measures, reducing 30-day readmissions, providing appropriate care across the continuum during the life cycle, from preconception to death. In other words, leveraging the knowledge of nurses. Here are some new model principles. You rethink the model of care. This is the current business model. The value in the current business model was basically more patients, more services, more revenue. It's how we made our money, fill up our hospitals, take care of everyone. And we're shifting from volume to value. It used to be that we needed to get our margin from more patients. Now we get our margin from better outcomes, or at least that's the hope of healthcare reform. No outcome, no income. It used to be no mission, no margin, no outcome, no income. The cost environment is going from cost management to totally changing the cost structure. I was being, a little funny about that cartoon, but in fact, we have to find ways to treat patients, prevent disease, and do it in a simpler, more inexpensive way. Utilization, hospitals were considered a growth industry in the old model. They're now considered a mature industry. Some economics professors would say a sunset industry. Vitally important to the populations they serve, but nobody really wants to invest in them anymore. Hospitals and doctors, parallel play. Doctors would come in, use the services of a hospital, and leave. The new model is highly coordinated and integrated. We cannot do this alone. Providers need to come together. They need to start talking with each other. Interprofessional relationships need to be embraced. Payment, basically, we were paid fee for service. The more you did, the more money you made. It's going to something else. And I don't think we're going to see what that's going to look like for the next 5 to 7 years. We're going to have a hybrid. We'll have some fee-for-service payment. We'll have some bundled rates. We will have a myriad of different payment schemes that will give CEOs like Eileen very big headaches. She already has it. System of care, patient services to care management. It's not just about what that patient's coming in the hospital for. It's how are we going to manage that care across the continuum so the patient doesn't come back in the hospital. And lastly, the importance of scale. Small and medium community hospitals could do very well in the old system. The importance of scale, big, bigger, biggest, is really important. Getting scale and scope in a marketplace to make yourself an indispensable asset to improving the population of health of your community is really important. So as we rethink the organization of care, the question for all providers is, where is your place? This is the continuum of care. Primary care, specialty care, outpatient hospital care, and ambulatory surgical centers, inpatient hospital care, long-term acute care, inpatient rehab, skilled nursing, home health. All of these components need to work together. And you can see the different types of reimbursement that will probably be coming forth in the next couple of years. We already know that medical homes, if primary care physicians and nurse practitioners take care of patients in what they call a primary medical home, meeting certain criteria, that you get a higher payment rate. Acute care bundling would include the primary physicians, the specialty physicians, outpatient and inpatient. The acute care episode with post-acute bundling could involve all of that. And then you have maybe just post-acute care episode bundling. What that means is we might get one bundle of money to share amongst the providers and take care of all the care. Now, this is something we're not used to. And most of our information technology systems and decision support systems are not prepared for this right now. This is what we're working towards. So what's the solution? Where do we even begin? I have a suggestion, of course. Ask the nurses. Nurses are one of the few disciplines that are educated in care across the continuum. one of the few disciplines where care coordination and plan of care is person-centered and holistic. Nursing is one of the few professions educated to work in all the various settings across the life cycle of individuals in your communities. Nursing is not or should not be a silent participant in healthcare reform, but rather the solution. Nurses are still considered the most trusted profession. But when the public was asked in an opinion poll, what impact do they think nurses have on reform? The perception is very little. Do we as nurses want to accept the challenge of being the solution to reform, or do we just want to be silent participants, or maybe even victims? You already know that nurse practitioners who are running clinics are now being challenged by the Family Practice Association. Any physicians in the audience? I love physicians. But why are you doing that? Come on. Why? Because suddenly there's going to be a little more money for primary care. So let's hold the nurses down. At this point, we're stuck between old and new. I've showed you the chart between the old model, the new model. We're sort of standing on the dock. One foot's on the dock. The other foot's on a rowboat that's going that way. Because part of what we're going to experience is being paid the old way while we're trying to move into the new way. I think this is the precise spot where nursing can, right now, make the biggest impact. As you know, there was a Supreme Court challenge to the individual mandate of the Affordable Care Act. The Supreme Court upheld the constitutionality of the individual mandate, but struck down the Medicaid expansion requirements for the states. So what does healthcare reform really look like? That's it. Look at that. I call, you know, when I tell my, when I tell my assistant, I was emailing her to get the slides together. We call this the colorful slide. I said, Laura, get the colorful slide. I'm just going to point you to this right here. That's pay for performance and penalties for poor performance provisions. Okay, rulemaking, hospital value-based purchasing, that's your compliance with core measures, and patient experience scores, patient satisfaction. Hospital readmission payment reductions. We are not getting paid for Medicare patients that are readmitted to the hospital within 30 days for any cause. Think about that. Patient comes in, has a heart attack, does really well, goes home, within 30 days, slips at home, breaks a hip, comes back. You may not get paid for that. In CHE alone, we had $2.8 million of penalties for readmissions for all causes. Some of it can't be helped. And then hospital-acquired conditions penalties. Hospital-acquired conditions, I know you're all familiar with them. Urinary tract infections, catheter-related urinary tract infections, I could go on and on. Nurses impact just about every item in the quality improvement domain. A Gallup poll, this is really important, conducted on behalf of the Robert Wood Johnson Foundation, found that opinion leaders, and these were you know, the Don Berwicks, the head of CMS, they found that opinion leaders feel that the nurses' primary areas of influence are reducing medical errors, improving quality of care, and coordinating patient care. Nurses are the solution to what we're struggling with right now. In collaboration with physicians, they can improve the quality of care currently delivered while decreasing the cost of care due to variation in errors. Let's look at the responsibilities that a CNO has in collaboration with a CMO. I'm not going to go through all these. You know them. Foreign object retained after surgery, air embolism, blood incompatibility, stage pressure ulcers, stage 3-4 pressure ulcers, falls with trauma, manifestations of poor glycemic control, catheter-associated UTI. All of these, nursing has such a big role in preventing. And when you prevent these things from happening, what do? You lower the cost of care. You decrease the variation, you improve the quality. Oh, there's more. How about the serious reportable events, the National Quality Forum? And you can just see the check marks of the implications of nursing on serious reportable events. There's a lot of them. This is the direct impact of good nursing in a facility. And I know you all know these, or you can go online and get them, but nursing has a direct impact in the quality of the care that we give. And they need to embrace this. They need to understand this is where they make a difference. The quality of care, the patient experience. So what do I think nurses should do? I think they're perfectly positioned to take control of reform initiatives if they choose to. The nursing profession is educated in care across the continuum with a holistic approach, has a core competency in care management and care coordination, has always focused on quality of care and patient safety. Nursing intervenes at every point in the patient experience and has always been the patient advocate. So maybe the question is not, what is the impact of reform on the nursing profession, but rather, how can nurses position themselves to have the greatest impact in a reformed healthcare environment? So here are some thoughts on that point. Advocate strongly and fiercely for allowing nurses to work to the top of their license. Nurse practitioners, clinical nurse specialists, advanced practice nurses need to be able to work to the top of their license. They can do 80 to 85% of everything that a primary care physician does. They should be rewarded financially for that, and no one should try to put them down. And I can tell you that's already starting. Primary Care Association, Physician Association is already trying to say nurse practitioners cannot work independently. Codify the science of nursing. Transform evidence more quickly to the bedside. We don't have enough nursing research. And the research that we do have takes 10 to 12 to 15 years to get to the bedside. We need to get translational research going and going right now, because you can make a difference in all of those serious reportable events, all of those core measures. You can improve quality through good nursing research. Be the transformational change agent you've always led with. How have we gotten through the world wars when all the physicians went overseas? Nurses did it. And should I remind you, during World War II, the mortality rate decreased during that time? Is there a correlation here? I don't know. Demand a place at the table to participate in the comparative effectiveness research that is in the bill. Nurses should be at that table. Embrace technology to break down silos across the continuum and into person's home, and I know that the VNA is already doing that. Understand fully the financing of healthcare. I was asked to be on a panel for the trustees of the University of Pennsylvania School of Nursing, and they said, and be controversial. Tell us what you think we should do with the curriculum. I said, teach nurses how this gets paid for. That's the first thing. You should walk in and say, I'm going to do community nursing. I'm going to do that clinical. But how does this get paid for? Expand educational opportunities to include economics and finance if you haven't already done that. Foster interprofessional collaboration. Go to the sweet spot of other professionals. I listened very intently to your characteristics of Sister Consuela. She listened to you, but she was present to you with all of her senses. Nurses, if you're present to the other professionals with all of your senses, you will be the natural leaders that people will seek, because you'll be inclusive. You'll take the lead in promoting better care and outcomes that make all members of the team feel worthwhile and part of something bigger than what they could do on their own. Focus on nursing's areas of influence: improving quality, reducing errors, coordinating care, promoting wellness, expanding preventative care, and improving efficiency. Let's talk about the white space in hospitals. Do you know what the white space is? Well, have any of you been a patient in the hospital? How many of you have sat outside radiology for 45 minutes waiting for that chest x-ray that took 3? That's the white space. That's the efficiency that those nurse leaders looking for the sweet spot and how to improve how we take care of patients can really help. Here's what's most important: help each other. Lean forward as you go forward in a reformed healthcare system, but also reach back. Be mentors and collaborators. Make sure that the people behind you are brought along with you. Engage in lifelong learning. I heard that about Sister Consuela as well. Demand a place at the table. Here's the most controversial one. Speak with one voice. I'm a diploma nurse that got a BSN. I learned great things from both. We have varying levels of nursing education. The tent is pretty large. We have a lot of work to do. I would rather spend time improving quality, coordinating care, promoting wellness, than fighting over who should be doing what with what degree. That's my bias. There's room for everybody in certain ways. We need more PhD nurses. We need more advanced practice nurses. We will make a difference. But at the end of the day, what we really need to do is speak with one voice. At the end of her life, this was Florence Nightingale's final guidance to us. May we hope that when we are all dead and gone, leaders will arise who have been personally experienced in the hard, practical work, the difficulties and the joys of organizing nursing reforms, and who will lead far beyond anything we have done. Well, that still stands today. Take her words to heart. Prepare yourself to contribute to the reforms that will take place at this point in time. In our lifetime, this is your time. This is a precious opportunity, and it's yours. I hope you embrace it. Thank you. I'd love to take questions. Anybody? Who has the first question? I don't know what the outcome of the election's going to be, but I do know, Susan and I were having this discussion, that no matter what happens, healthcare, it's just too expensive. It's just engulfing us. And at the end of the day, there's got to be reform. I think if Romney gets in, it'll be stalled, but things will still have to change. And I think if Obama gets in, we'll continue on the course that we're on. But at the end of the day, it's got to change. Yes, Kath? Sure, I'd love to. Well, the first thing, this is interesting, when I spoke to the Penn nurses, I said to the faculty, there's a lot of faculty there, I said, do you tell your graduates that when they apply for a job, that they should ask if a nurse is on the board? If there's not a nurse on the board, you really got to question, what does that organization think about nursing? The first thing I did was, hired a PhD CNO, Chief Nurse Officer, Nora Triola. She's wonderful. And she is moving all the quality initiatives with task forces of nursing throughout Catholic Health East. She is making a difference. The board now says, when they want to hear about quality, they have Nora speak. I also appointed Roberta Waite, Dr. Roberta Waite, who is a professor at Drexel University College of Nursing, who runs nurse-led clinics in Philadelphia, in the poorest sections of Philadelphia, to the board. So our nursing group, in fact, they get together a lot on conference calls. Once a year, we have a 2-day seminar for our chief nurse officers. And once a year, we're now bringing together our CNOs and CMOs. Next week, they'll be together for 2 days, talking about that interprofessional work that is so vital. Does that help? She's brilliant, too. I learned so much from her every day. Yes, it did. Yes.
I noticed you very quickly mentioned education for nurses and finance and economics.
Mm-hmm.
Would you elaborate on that a little more? The nursing program is so full of what they need to take that I would presume it would have to go along with the other subjects that they take in college.
Yeah, I can just tell you what I've experienced. At Penn, they have the nurses can also get a degree from Wharton. And it's 5 years, it's not the 4 years. I have to agree with you that the nursing curriculum to cover everything, I don't know how many credits yours is, but I swear that mine was about 1,200. Of course, I was a diploma nurse, so we really thought we knew everything, and I had 5 years experience, and they gave me 5 credits. I was really proud of that. And I then went ahead to, challenge the 2 years. I think what it is a conversation. The nurses that are inclined to want to learn more will go ahead and learn more. But I always thought it would be really important when you're going through your clinical to have a lecture on, do you know how patients enter the system? Do you understand about insurance? What is going on now? How is home health paid for? Sometimes it's just part of a lecture before a nurse goes out to the clinical, because that's part of the holistic nature of who they're taking care of, is understanding the financial burden they may be having. So it may just be able to be inculcated into what the general clinical. And then for those nurses that are interested in learning more, they could go on to take. You're at a vast college here. I'm sure you have some great courses that they could take that would be valuable. That would be the way I would do it, but I'm not a curriculum. I don't put curriculums together. I just espouse things. Yes. Yeah, it's interesting. And definitely at the graduate. Yeah. Eileen. That's a great question. When we talk about healthcare, people automatically think about hospitals. I was interviewed by a reporter. We were 3/4 the way through the interview. I was talking about healthcare across the continuum. And every time I said healthcare, she was thinking hospital. Finally, she just said, "Stop. You're not talking about a hospital, are you?" I said, "No, I'm talking about being responsible for care across the continuum." And we're so ingrained in that business model. And it's going to take a while for that change as we start moving people into the community. And what's going to happen, this is my fear, to be honest, is that the hospitals their volume's decreasing, as you know. It's happening everywhere. There's not going to be jobs in the hospital. And then you say, okay, what is you definitely need some experience to be on your own in the community. And we need somehow to bridge that gap, Eileen, because you can't send a new grad out into the community without that support system. I had a discussion with, you've heard of Bayeda nurses. That's the largest home nursing division in the United States. It's in 28 states, and I think it's international. Did you ever see those commercials where there's a guy on a respirator and it's pouring rain out and the nurse is driving Don't worry, I'll get there. Well, it's the Bayada nurses, B-A-Y-A-D-A. I love that commercial because it's really heartrending. But at the end of the day, I was talking to him about it because he said he has openings, but he needs experienced nurses. And he's coming to visit me because I said, have you ever thought about using information technology to connect the less seasoned nurse that's out in the community, almost like a EICU, to a bank of seasoned nurses? I mean, we're going to have to do something like that. So when a BSN grad comes out and the opening is in the community and she or he gonna go into someone's home, they can't be on their own. But you know, the EICUs, if you're familiar with that concept, where they the major hub actually monitors patients that are critical care access hospitals that are, you know, out in who knows where. They're way out and they can't afford intensivists. They have nurses and physicians that through information technology monitor the patients for them. So I think we have to start leveraging technology to help nurses move across the continuum. The hospital is a safe place. You know, we have a safety net at the hospital, especially for new graduates. The community is a scary place. You know, I was an ICU nurse, but I always had people that were around me. I could touch them, I could pull them in, they could help me. I have such respect for visiting nurses who are out there on their own. They walk into someone's house, and who knows what they're going to find. So I think technology might be an answer, Colleen. It's just a thought. Yes? Yeah, that's a great example of how you can leverage some technology, very simple technology, to support nurses in the field. Any other questions? No one said this was going to be easy. And I do expect that the next 5 to 10 years are going to be difficult. I say 5 to 7, I round down. 5 to 7 years, I have a tendency to do that. But I really think that for all of us that are blessed with the stories, that if we continue to tell the stories, whether they're the Sister Consuela stories, our founding congregation stories, how did they do it? How did they do that? Well, courage and joy and hope, those stories are life-giving to us. So we have to keep reminding ourselves, if we think this is difficult, it's not nearly as difficult as some of our founding congregations went through 100 years ago. So, I say, what would the sisters do? We'll figure it out. Thank you.
Judy, thank you for such an inspirational and thought-provoking presentation. It gives us all a lot of food for thought. I'd like to, in recognition of your coming here and visiting us today, I'd like to offer you a small token of our appreciation that we'd like you to take home and enjoy. Remember the evening. I was going to say, I don't know if it'll be a part of carry-on, but we'll hope so. And I also wanted to take a moment and thank you all for taking time at the end of busy weeks to come and be a part of this celebration. We greatly appreciate the sponsorship of Mercy Hospital, and as I said, it's wonderful to be a part of a collaborative type of a venture like this. So we're looking forward to perhaps this being the first of more. But in the meantime, I want to thank you again for attending and safe travels for you on your trips home. Thank you.